Ladies and gentlemen, this is going to be a great session because we have three esteemed speakers lined up for you. We have Dr. Zubin Othman Ibrahim, Consultant Cardiologist and Physician at Ara Damansara Medical Centre, Dr. Chong Yoon Sin, Consultant Cardiologist at ParkCity Medical Centre, Dr. Koh Kok Wei, Consultant Cardiologist at Subang Jaya Medical Centre. Without further ado, let's welcome Dr. Zubin Othman Ibrahim onto the stage to share with us BMI and cholesterol and its correlation to heart diseases.
Okay, good morning. It's nice to see a whole bunch of people filling up a lecture hall Saturday morning, yeah? Okay, this is the first talk. We'll keep it as straightforward as possible. We've got two other lectures that we need to go through. And it is I think it is a very basic topic. We all know how important it is to keep ourselves healthy, a good diet and exercise, but we don't seem to be able to know how to do it, okay? This is my favorite organ. As long as I am doing my work in the clinic, everything which the patient does is so that the heart is all right. And we can say all about how the heart functions, but we don't look after our health from the start, then we are in trouble. Let's bring this closer. Okay, these are all kind of basic things. I was lecturing at a university until about 1.5 years ago. If there's any questions, you can kind of straight away ask if there's anything which is unclear. But we do have that session at the end of the three talks, yeah? Okay, when we talk about heart disease, we'll just focus on the main reasons. How does the heart go wrong? The most common things will be... Okay, so the most common things will be that the pipes or the vessel supplying the heart is blocked, for example. That's coronary artery disease. Next will be the valves, which are involved in just making sure that the heart, as a pump, is working. They allow the blood to go through each chamber, and it closes when it needs to be. Okay? And then when the heart kind of rhythm is not working, it can be too slow, too fast, or it stops, that's called an arrhythmia. Okay? And what happens when the muscle itself somehow fails due to no clear reason, that's called a cardiomyopathy. Okay? And in the end, if any of these kind of processes, and they progress without us treating it, then all of this heart disease kind of infections will cause heart failure. We'll go through this. This is what I'm kind of the main gist of things which we see in all hospitals in this country. There's coronary artery disease. The pipes are blocked. It's not just the large pipes, but it's also the smaller vessels in the muscles. Okay, we'll go through this. And this is what it may look like when somebody gets a heart attack. Chest pain, we may be familiar with this. Somebody came up to me just now and asked, do all patients with heart disease get chest pain? No. It's probably about 40 to 60% do get chest pain. Some just get a feeling that their chest is tight. There may be some problem with the breathing. And some may have stomach pains, for example, and it may be confused with ulcers or reflux for a long period until we get the diagnosis. Some may not even have any symptoms and their heart stops. So this is what we need to know, but it's not in our kind of the topic now. This is what happens when the valve does not function well. Okay, so the blood is supposed to go from one chamber to the other. If you are born with a faulty valve, if you get an infection to your valve, then these things don't work properly. All right? Okay, and Dr. Koh will talk about this later on. If this is, so the heart is like an engine, some of us like cars here, so we have the carburetor as the heart itself, we have the pipes as our vessels, we have the wiring as our conduction system in our heart. All of this will make the heart function well, or if something goes wrong, then there's heart disease. And this is if the heart muscle itself does not function well, it's called a cardiomyopathy. Some are born with the gene which, after a while, the heart muscle does not pump right, and it gets floppy, for example. Okay? But mainly the main issue with all of this heart disease is if it is not treated properly, then you see patients with heart failure, lemah jantung, for example. There is fluid in the lungs, there's fluid in the legs, the patient can't sleep well. This is heart failure where it has failed to be treated well. And all of those 3-4 things which I've mentioned just now can cause heart failure, or will cause heart failure if it is not treated well. This is not that's a rusty pipe. Hopefully none of ours is like this. This is my analogy of how the vessels look like if we'd had too much time enjoying our food maybe, or with further risk factors. We are looking at the vessels which are supplying the heart muscle itself, and with time you may have some cholesterol or streaks of fat even as early as 15 or 20 years old. And with time, if something else happens, for example, we get diabetes, get hypertension, all of this will further speed or just accelerate the disease process. Okay, so just go back to the major talk, which I will try and start now. We know about the risk factors: smoking, hypertension, diabetes. I will focus now on obesity, which has got its whole kind of complex with the other problem, which is not being able to do exercise or physical inactivity. Okay, and the final one will be high cholesterol. When we are in a health talk, when you are talking with doctors, you will see some maybe gruesome images, which might make us squirm. So the next slide is quite scary. Yeah. Okay, that's me when I was a bit younger. Okay, that's at med school, and so studying medicine is unhealthy. Okay, you don't go for exercise, you eat too much, and depending on which country you go to, you may be enjoying too much of the local produce. Okay, and when you're training and when you're working, and it goes to all kind of levels of work in this country. We are too busy trying to get our skills. We are too busy trying to get the deadline. I have patients who are younger than us, younger than me, and their hours are bad. It's the shift work, and how we decide to work, how we decide. Not all of us are lucky enough to get a good job where we can go home and go back to exercise, for example. Okay, times are tight, and even though that we start off healthy when we are, say, studying, we may, really balloon and make things hard for ourselves. This is a long time ago, I think. The one on the right is taking his exams PT3 next year, and the one on the left has just finished his UPSR on Friday. So that was some time ago. Okay, 99 kilos, yeah, 99 kilos. Okay, thank you very much. Okay, so I chose some slides from the earlier lectures which I showed in Indonesia. They were quite happy to see that we are outdoing them in a few things, and they were also pleased that this is one reason why we've been losing our Thomas Cup so often. We are winning this thing very well, and it's a big concern. We are seeing all our patients coming in younger than their parents, younger than their grandparents. The older group or the more senior group in this hall, I tell you, a lot of you guys are healthier than the ones in my generation, for example. Okay, and I think it's a fact. You all are working a bit harder to look after yourselves, and people my age or younger even are not doing ourselves service. Okay, I mean, we can go on and on with this, but we know that obesity has been on for so long. We've talked about it. It's been described in ancient Greece and Roman texts. We talk about it in texts in the Quran and also in the Sunnah. We also know that I think Confucius said something about food that have to prepare it well. We started to see the effects of unhealthiness towards the turn of the century. after the war, when there was more and more corn which was used, more wheat which was used. And towards the 1920s, 1930s, insurance companies started to get interested. Okay, this is when industry comes in and tells us that, okay, people who are a bit overweight, they die earlier. And this was an interesting fact from this kind of survey which was done. So it's been known earlier. We've only got more data since then. Ansel Keys is a physiologist. Some of us here may understand that his techniques were not that great all the while. There's some controversy in how we look at fat and cholesterol and carbs, for example. But it is clear that obesity, however it can happen, is a mainstay in how we get heart disease. Yeah, and we are still studying about it. The amount of scientific kind of material that we have is ongoing. We are getting to know more about it, and how do we not say that this is something important? Everybody in this room may have a say about it. Everybody outside this room who has the means to change things, certainly we understand what it has to be done. Okay, so we used to just think that from obesity it causes diabetes, from obesity it causes hypertension, from obesity it causes other diseases which are the major risk factors for heart disease. But now it is very clear that with just being overweight, slightly overweight, say a BMI of 26 and above, not even reaching a BMI of 30, there are already some physiological, some hormonal changes to our body, affecting our kidneys, affecting our blood vessels. And I'm not here to talk about this too much because there's plenty of information out there. We have to trust the people who are doing all of this good research. And occasionally I do see from social media that being fat is okay, for example. Even the word fat is kind of making us cringe a bit because it's not PC, for example, okay? But we do have to understand that when we do large studies looking at some patients, you've heard about the J curve. So when you somehow are at a certain lowest level of weight, you are at your sickest, and then you go up, and a certain level of slightly more, EC or flesh is okay, but it's not like that. The J curve is certainly still controversial. We have to understand that as much as possible, we keep our weight down, and through the means that we know. Okay, this is a picture outside the school. Okay, and then you can see the soft drinks, and these are young kids. And instead of getting maybe healthy, packed lunch from home, they are getting this at home. So we know that from our PEDS colleagues, from the doctors who are researching in obesity in children, it has started more than 20 years ago that our kids are getting more obese, and they are already becoming adults who are obese, and a lot of females who are pregnant, they are obese, and all of this goes down to their kids. Okay, and it's something that we have to understand, and I don't think any doctor here will be able to solve this problem on their own. It's part of the community as well. This is a true kind of menu from a restaurant in the States. True story. It is scary the amount of cheese that the Americans like to put on their burgers, on the chips. I mean, we know that it is. We do enjoy our food. I am a Malaysian. We do enjoy a bit of cheese or beef and stuff, but we have to understand that there's always the limits that we have so that we don't make ourselves sick. Okay, this is what we used to see more often. That means people did not require gyms. Okay, we do not need gyms then. Why? Because the work itself was full of physical activity. Even though they ate rice maybe 2 or 3 times a day in the fields, they still were healthy. Okay, and this is what I'm not saying everybody needs to go back to fishing, for example, no, but the kind of work that we do and how we do it, where we expose ourselves to bad times and bad eating practices from our school days will cause this. So that patient on the right, not patient, he's not my patient. That person on the right had just slept over his chair because of something probably called sleep apnea. He did not get a good night's sleep because of his obesity. Okay, it's something that we know certainly affects our heart, our we call it the things like hypertension, and is a major problem as well. Okay, all right. We know all about this. We occasionally forget when we are visiting our local restaurant for our tosi and our teh tarik, but it starts off very easily. It just starts off when we are in our teens, 17, 18, bad food practices. It goes on when we are too busy looking after our work and we are trying to get our training done. And from the musculoskeletal, our joints, we have patients who are overly obese and they are not able to exercise. And once they get into that situation where they can't even go upstairs, then they gain weight much more easier. Okay? And from there, things like sleep apnea will make things like hypertension worse. And all of this will contribute to heart disease. There's still hope for us. Okay, that guy on the right, on the left is, I think, a 72-year-old Japanese person. He's been healthy only for the last, I think, 15 years. He looks quite cool. I am sorry for the female side of this audience. If your other half turns like this in the next few years, it's for his good as well. Okay, don't be too worried. Okay, so we've known that. So we've known that even though we are overweight, even though we are unwell with heart disease, stopping whatever we are doing which is causing that, as in stopping all the kind of bad practices, and we start to move, start to walk, start to exercise at any stage of our life, at any stage of disease, even with heart disease, even after a heart attack, even after a bypass, it will make a big difference. Okay, we just have to tailor whatever we need with exercise and whatever we can do. If our joints are painful, we may have to start off walking, for example, walking in the pool, for example. Okay, nobody will expect somebody who's overweight to go up and run straight away. Running can be dangerous. If we get an injury when we are 40, 50, it makes us go backwards, for example. So there's a lot of things that we can do, and I have patients who have lost 20, 30 kilos just by understanding that they have already gone overboard, and it's time for them to make sure that they can get healthy again. Okay, so the formula seems easy, and if I put this at the start of the slide, everybody can lead a healthy life. But no, it's not. Okay. Every single thing which makes us human beings, which makes us Malaysian, Asian, all of this is important. Okay, do we have enough social support for patients who are unable to afford good, healthy food? For example, in New Zealand, when I was training the Maoris and the Pacific Islanders, and these were the people who were more obese because it was easy for them to get just cheap carbohydrates, for example, whereas protein was expensive, vegetable was expensive, and we see this here in Malaysia, where just plain simple carbohydrates is easy for people who are less affluent to get food, and small things like this when they are in their school years, when we are working, it will certainly make things kind of different. So it's not only the role of the doctor, it's the culture that we live in. How much time does the patient get when they see the doctor? For example, how much time can the doctor give the patient trying to figure out what can happen? The patient comes in with just tiredness to the GP. Have they asked about sleep apnea, for example? And the only thing which can be wrong or may be wrong with that patient is the patient is overweight or obese, causing sleep apnea, for example. Okay, that was my effort 4 or 5 years ago. That's my number 3 kid. It's right now in in our circles now, in the cardiologists, we are trying our best to show that we are healthy people as well, and it's tough, okay? To some extent, I've managed a bit, found something that I liked, some exercise, going up mountains where at least there's something that we can do, go back to sports that we like, and all of us may have this history that we used to like something, for example, when we were a bit younger. Okay, walking is a good start, sports is a good thing for us. That small picture down there is my son's school sports day. I think I got number 2. There were 3 people. Okay, just a few slides about cholesterol. There may have been some debate about cholesterol in the last 3 or 4 years from the US dietary review that they did from just a population-based study. But I will have to say that, again, a lot has been researched about cholesterol from the 1940s. It is clear that all of these processes that we see in this busy slide, we understand that cholesterol is heavily involved in the process of atherosclerosis, and it is involved in every single stage, from the start, when somebody gets a heart attack, and if we want some treatment from the patient. And bringing down your cholesterol, if it is high, does help, certainly if you have heart disease. Doctors, occasionally, we focus on cholesterol too much and we forget about the other stuff, forget about cigarette smoking, hypertension, diabetes. And when that happens, we are relying on maybe just medications only. It must be a holistic thing, not certainly in any patient, in most patients with heart disease, it's not only one risk factor. Okay, there's a whole range of things. So just by focusing on cholesterol may have led us to be a bit too worried about one single thing, but we have to go the whole circle. Cholesterol is very important. If you take statins, for example, after heart attack, after bypass, after stenting, that works, okay, and at all ages. Just one example to see how important cholesterol is. This is a young female, 38 years old. She's been having abdominal pains for about 2 years, and her cholesterol is 12.4. Normal would be around anything less than 5. That's for total cholesterol. Her LDL, which is the bad cholesterol, which we say, is 10. Mine now is 1.9 with medications. And what you all see is, you may be able to see that is one area here which is not kind of filling up nicely, and that's where a stenosis, or there's a narrowing there. And then one question which I asked was, is there any family history? And her father passed away at the age of 35, and that was easy enough for us to figure out, with that cholesterol, with that history of abdominal pain, that was her angina, that was her chest pain. So cholesterol does cause heart disease. We can't run away from it, especially if we have faulty genes, for example, and through dietary and lifestyle measures, certainly we can fix things. So this patient had a statin and she's all right, but her story is not just there. She's got other disease elsewhere, and we need to make sure that she's on the medication, comes in for kind of follow-ups, make sure that she doesn't have all those symptoms again, because these stents can reblock again. Okay, I think I'm finishing soon. So to summarize, there is a clear role of obesity and cholesterol in the development of heart disease in all stages. The standing of obesity and cholesterol is, at this stage, clear. We may certainly have new findings later on. What is right now might not be right in the next 4 or 5 years. But at this stage, all doctors will understand that for us to treat patients now and in the future, we have to figure out how to prevent obesity in our young patients. If somebody has got high cholesterol now, we have to make sure that there are other risk factors that we need to control, and we have to treat it well. Okay, so another thing which I like to do is to take photos, and this is the photos in India when I tracked up about 2-week course, and this guy is 81 years old. 81 years old, and he was in charge of our horses. Every day after the camp, he would let the horses roam around the campsite. And at 3 o'clock in the morning, this man, Tashi, would go out in a radius of about 10 kilometers to look for the horses back again for our next morning. So he walked a lot. So walking is good. It's something which helps us with our joints and our muscles, and we can prevent obesity. Thank you very much.
Thank you very much, Dr. Zubin. Let's give him another round of applause. Ladies and gentlemen, please join me in welcoming Dr. Chong Yoon Sin onto the stage to talk about early detection and treatment of heart diseases. Dr. Chong?
Good morning. My name is Dr. Chong here. Thank you for coming in the good Saturday morning. I'm sure all of you come here to learn something about heart disease. All right, I'm Dr. Chong from ParkCity Medical Centre. Two things before I start. First thing is that how to keep your heart healthy. I want all of you to stand up, stand up, stand up. Because a lot of you are sleepy already. Okay, all right, thank you very much. Move up your hand. All right, turn around. All right, good. All right, it make your heart move, all right? It make your heart move. The second thing is that we live in this world very short. Okay, turn to your right and then say hello, my name is so-and-so, shake the hand, all right, shake your hand. And then turn to the left and shake your hand, say I'm so-and-so, all right? Break the ice, all right? Break the ice. You know, because cannot be strangers sitting next to you, all right? We're all new Malaysian. We are new Malaysian. All right, come, take a seat, take a seat. Thanks. Yeah, feel better now? Yes, of course. All right, thank you. Today I'm going to talk to you about the heart disease and all right, this is how to prevent cardiac catastrophe. All right, a lot of time things happen, boom, just like that. All right, a lot of time they say, hey, yesterday I see Uncle so and so, but then that night no more. It's very, very common, and we do not want this kind of thing to happen to any of our family member because today, heart disease is preventable. All right, Mahathir said that today we have the science and technology that to keep him alive until so long. He got a heart attack, he got 2 bypass, and he still stands strong today in New York. All right? Yep. So heart disease can be prevented, heart disease can be treated, so don't take it as an end. All right? A lot of time people do not follow the advice of the doctor. People do not take the advantage of the technology, to keep him alive. All right? So it's important that we have, as in today, we have all the sciences, we have all the evidence, we have all the technology to detect heart disease, we have all the treatment to treat heart problem before anything turn bad. All right, this is catastrophic. All right, this is natural disaster. People do not want this. This one come in, cannot do anything. All right, I want you to break the ice because we never know what will happen next. All right, it just happened in Indonesia, another earthquake come about, so we never know what is tomorrow. But what we can do is that, for human being, for heart disease, we can prevent heart disease, all right? A lot of time, we do not want our loved one to happen just like that, all right? If it's predicted, yes, all right? But if it's unpredicted, all this event of a so-called heart attack of sudden happen and no more, can be prevented with today's science and technology, all right? And yourself have to put effort into it to make sure that this thing doesn't happen, all right? So a lot of time as today, more and more people who come with heart problems do speak in the society. And more of these people come to see me getting younger and younger. And a lot of them are early 30s, early 30s. They sit in front of me, all younger than me, all of them getting a heart attack, 90% block, and so on. And all because of stress, food, and poor healthy lifestyle. They know these are bad, they smoke. I know this is bad, but they still smoke. All right? I know the food is not good, but they still eat. All right? So all these contribute to a young person who get a heart attack early, and they do not do a medical checkup because they think they're too young. All right? So always important that because these people who actually, if let's say they get a heart attack, suddenly pass away, they are the main contributor to the family. Their children are still very young. All right? And the family cannot accept this. And these are the people who actually contribute to the economy. all right? They contribute income tax, all right, for the country to grow. So these are important pillars of the family and country. So we cannot lose them, all right? Just because of one tiny vessel, loss of life is actually not worth it, all right? So this is a census from the Statistic Department of Malaysia. In 2016, we have 80,000 deaths. And you look at it, heart disease, which is a heart attack, is 13.2%, which is 11,000 people who actually pass. If you calculate this number, we actually have more than 30 patients died per hour. If you count minus 360 per day. And if you look at it, basically every hour, there is one person die of heart problem in Malaysia. Every hour. Imagine how bad is it? It's actually very, very bad. And if you look at other cases like this is chest infection, 10,000, stroke, 5,000, road traffic accident, about 4,000, and cancer is about 2,000. So basically, in this part of the world, Malaysia, we have a major issue of death from heart problem. It's almost 11,000 per year, which is equivalent to 30 per day, and every hour, almost one die of heart problem. It's serious, isn't it? It's very, very serious. And these are the people that we are seeing getting younger and younger and younger. They are the family pillar, they are the country pillar. And among all these people, 17% of them, 15% of them are heart disease from male, about 8,000. And female tend to be more of infective causes like chest infection. And 3,000 are heart attack. So 70% of the people who get heart problem and die are male. So male are the most important patient who actually develop heart problems, all right? Because female, usually they have hormone. The hormone actually protect the heart and they make them protected. But the moment they stop the menses, that's when things happen. All right, so how to prevent this, all right? So two things only, I make it very simple. Early detection, early treatment. And these two are available, all right, as in today, what we have. Also very important is that how do we early detect? First, you must recognize the symptoms, all right? It's very, very important. You must recognize the symptoms. So this is a classic picture of heart attack, all right? Suddenly after the badminton game, you feel very uncomfortable, sweating, the whole shirt all wet. You use two hands to press on the chest, say, I cannot breathe, I cannot breathe. So any of your loved one, friends, colleague, or your neighbor, just now you say hello, who have this, please bring them to hospital immediately, all right? Immediately, all right? There are cases a couple of days ago, they went to see a GP, did an ECG, they say, probably one block. Okay, then they say, one block, not that bad. So they went, instead of going to the hospital, they go home to pack clothes. So after that, never come out from the room. That's it. By the time they bring in, it's already dead. So always, any of these issues arise, regardless who is it, bring them to the hospital immediately, all right? Don't go home and pack clothes. So this is classic, but a lot of time this classic doesn't happen, all right? So a lot of time they present something else. They present with the pain, so-called jaw pain. So they go and see a dentist. Actually, they have heart attack, right? They go and see, they have shoulder pain. They see orthopedics, all right? And then sometimes they actually presented with epigastric pain. It's stomach. It's not heart. It's not heart. So they actually went to see a gastro or a stomach doctor and actually found out it's actually a heart attack. So a lot of time, if you're not sure, come and see the doctor, because the pain can be vary from neck, to the jaw, to the arm, and to the epigastric area. So anyway around the heart is actually can be possible heart attack. Can be, I would say, but you need to see a medical profession to exclude it's a heart problem, all right? Because it depends which blood vessel is blocked. It contributes differently, all right? Of course, some people actually present with breathlessness, so they walk a bit, they're breathless, and then the friend will say, hey, actually you're having gastric. It's actually no, it's actually a heart problem, all right? When we fix the heart, they say, hey, uncle, you actually have very bad heart. We fix it, now you feel better? Yes. I say, why you didn't come and see us? No experience. We thought of pain, like just now the picture, uncle had pain. It's not, it's breathlessness. So no experience is one of the excuses. That's why early detection by understanding the sign and symptoms is very important. All right, some people will present with palpitation, all right? The heart, something bounding, not right, And some people will feel giddy, lightheaded because pressure low, or sometimes heart rate very low. And sometimes they present with cold sweats, nausea, vomiting, or sometimes they just collapse. All right? If a person who having a heart attack and they collapse, the chances of them wake up, can be 50-50. All right? Sometimes they never wake up. All right? Because the heart stopped already. So it's very important that you recognize that beside the first classical symptom that people have, that's what everybody been programmed into that. It can present in many, many forms. All right? A lot of time, they say, no, I don't have pain, But actually they're having a heart attack. They're having a jaw pain, neck pain, epigastric pain, breathlessness, a bit funny things and things like that. It can be a way of presenting a heart. And sometimes male and female can present differently. Man is usually more classics, any of the pain, difficult to breathe, can be back pain, jaw pain, neck pain, and things like that. But female can be a little bit subtle, all right? They can present with a bit giddy, a bit of nausea, very tired, cold sweat, a bit of heartburn feeling. So different. So male and female can present differently, all right? So female more sensitive. So it can be presented differently. So don't assume that everything is all right. So in case of anything that you suspect, if you feel that the symptoms is very uncomfortable, emergency. If you feel that symptom can wait, go to the clinic, all right? Either GP clinic or specialist clinic, it's up to your choice. You can judge yourself how bad are you at that point in time, but don't wait until the last minutes, all right? The moment you feel a little bit not right, go to the emergency or the clinic. All right, just to tell you what is actually happening, all right? This is actually only one thing that happened. This is because of the blood vessels, all right? This pipe block, that's the problem, all right? This is our pipe in the heart, all right? It's the blood vessels. And this is a normal pipe which actually carry oxygen and nutrition across it to supply the nutrient and oxygen to the heart so that the heart can continue to pump. So what happens is that if you eat unhealthy diet, like what Dr. Zubin actually explained to you, then you start to accumulate cholesterol, all right? That cholesterol will deposit in the vessel and over time accumulate, all right? You can see that it accumulate, and almost block off. This is what happened over the progression of the disease. So over here, you're healthy. Here, you don't feel much. Here, probably the stress test will be positive and you feel symptoms. And here is a heart attack that actually occur and you may not survive, all right? This is actually what happened. And a lot of times is that as the people get more and more cholesterol, and this is what the cholesterol plaque so much, and usually very cheesy. If you open the blood vessel, it looks like a cheesecake, I mean a pizza with extra cheese, all right? Okay, so this is very, very bad. And when you have this, actually, it's become a little bit unstable, okay? Because the blood actually flow through this area, all right? Flow through this area. So normal time, you're fine. So, but in case of you play game, excited, angry, agitated, the pressure went up, the pressure go through this area will be very forceful, and sometimes it can crack it, and form a clot. That's what, a person very normal, healthy, suddenly the plaque crack, and it form a clot inside the vessel, it occluded it, that's when heart attack happened. All right, this is a picture to show you. So what happened is that you have a cholesterol plaque here, and this plaque can be unstable, all right, because it's cheese. So the pressure is always go through here, all right? Our normal pressure, 120 millimmercury, so here. So when you play game, excited, angry, agitated, scolding people, the pressure go through here, forceful. So it will kick, and then it will crack the plaque, and that plaque is just like when you scratch it, it will form clot. And we form clot enough to block off the vessel, the blood cannot flow through, you have a problem here. That's when heart attack occur, and it occur in a split second, all right? And this is when happen is that you have a blood vessel of the heart on the surface of the heart, all right? So here, you can have a blockage, the blood cannot flow through, the cholesterol plaque crack, and you form a clot inside here, and the blood cannot go down to the muscle here is damaged. And that damage, immediate damage, lead you to a chest pain, difficult to breathe, unwell, sweating, and because it's screaming for oxygen, all right? So when that is not treated, the heart can stop, can be damaged, and this is, if you cut a section here, you can see the blood vessel with all the clot here, and when the blood doesn't flow through, the muscle is dead, it's pale, you can see that? It's pale. All right, this is exactly what happened during heart attack. Such a small thing, can disturb the heart and make the heart stop, and you're gone. All right, so just like that. So it's very, very important. Such a tiny thing can control our life. So a lot of times, more than 30% of the time, this is what happened. They either drop at the site, died, or they manage to bring to the hospital half alive, or if they're alive, then we have to try to do whatever we can. All right. A lot of time we do not want to wait until this situation happen, then only regret and want to do something. It's too late. All right. All these things can be done beforehand. And a lot of time as a doctor, we want to treat you before you got heart attack. We do not want to treat you after you got a heart attack, because once you get a heart attack, number one, you may not survive. Number two, even though you survive, your muscle is damaged. And when your muscle is damaged, you end up with a dilated heart, a weakened heart. And no point. We walk a bit breathless, heart filled with water, legs swollen. There's no quality of life. All right? Because we do not want the heart damage. The moment the heart damage, you have to put a lot of tablets and things like that. So a lot of time we want to treat you before your heart damage. All right? So this is what at the X-ray they show that normal heart, dilated heart. All right? If you don't treat it. Okay. Now you understand the signs and symptoms and the pathology of this. We're going to see what are the technology that we have today to look at it. So as a person, regular screening, and we have some of the medical tests to see whether there is such problems or not. I would advise that for people who are 40 and below, every 2-3 years, they have a medical examination. 40 and 50 years old, maybe every 2 years. 50 and above, I would say yearly checkup. Yearly checkup to make sure that you're healthy and you can go for holiday. All right? All right. So these are the tests that we actually normally do. We have a blood test, ECG, ultrasound the heart, stress test, and of course some advanced tests like a heart scan and angiogram. Those are the tests that to look at whether the blood vessels there's any evidence of blockage. So this is a common test that can be done anywhere, in the clinic, in the lab, in the hospital, a blood test. All right? A blood test can tell you so many things, But basically what you need to know is that whether you have enough blood, your kidney okay or not, your liver okay or not, sugar okay or not, cholesterol okay or not. That's the most important of all. All right? If you know that these major things are all right, the rest is optional. You can take any test you want. There are now thousands of tests you want to do if you want to. Of course, during emergency time, we can also do some cardiac marker to see whether there are any possible blood vessel block at that point in time or not. All right? But it's a simple test. It's a needle prick test, and it's worthwhile doing it in 1 to 2 years, depending on your age. All right? It's a simple test. It can be done everywhere. And of course, a simple test like ECG is very important. All right. So ECG is basically just put on some lead, and then after that we see the rhythm pattern, see any problems or not. All right. So it's also a test we recommended. If let's say you're having a chest pain or something not sure, it's worthwhile to go to the hospitals or the clinic to have an ECG done. If ECG is normal, then we can wait. All right. If ECG is abnormal, go to the hospital immediately without anything. All right. So this is actually a very simple test, not expensive, and everywhere you can find this. The ministry already set up a guideline. Every clinic must have an ECG machine. All right? So every clinic must have this. So this is a very good test to say, hey, at the moment you're all right. Because let's say you have some symptom that you're not sure, whether it's heart attack or not, ECG will help you to say you are okay or not at that point in time. All right? And then, some of the hospital we have an ultrasound to see whether the heart pump and structure and function, whether they're all right or not, whether they have enlargement, whether the valve is okay, the pump is strong. And this is ultrasound, and it's not dangerous. And of course, this ultrasound show that, the heart is enlarged. This is an enlarged heart. This side is a muscle thickness is okay. This is thinner and thinner. This is enlarged. Basically, this person has a heart attack in the past, causing muscle thickness and weakening of the heart. So ultrasound can show you this. So this is a very good screening test for public. All right, for public. It's called a stress test. A stress test is a simple test, can be done in some selected clinic, hospitals and cardio clinic. So this test, if you can walk and things like that, all right, it's worthwhile to do it regularly. So we hook it on and see whether any problems or not. if let's say the test is not 100% accurate, I would say 80 to 85% accurate, but it's a good public screening test to see whether any possible blood vessel blockage or not. All right. If let's say there are pattern changes, all right, then we look at the patient profile as a whole. Then we look at whether there's any possible blood vessel blockage or not. All right. It's a simple test, but the person must be able to walk. All right. Okay. Of course, nowadays with modern technology, we can have a lot of hi-fi things nowadays. So one of the advanced things that we have is called a heart scan. All right. Heart scan is a CT scan machine. All right. You put on the lid and then go inside the chamber, take a deep breath, hold, and then we can get a picture out. That's all. And nowadays, the technology is so modern, it's like a movie like that. We can, in the computer, we take out the heart. This is a heart. We can rotate the heart, turn up and down. We can open the heart, look at the vessels, Like in a movie, exactly, it's real. Turn around and things like that. I like this, very fun. It's very fun, But of course, it's not cheap. This is not cheap. That's why we cannot offer this to all public. This is not cheap. And of course, this one cost is issue. Radiation, small amount, yes, is there. Dye is there. And also, the person must be able to hold breath. If your heart, when we do the scan, we want the heart rate to be 50 to 60. If your heart rate very fast or very kanchong, go inside the chamber, the heartbeat very fast, then no. Because this is a moving object. Heart is a moving object. So when we scan, in the whole body, the only organ move is heart. So we are scanning a moving heart. So we need to slow it down to 50 to 60. Then you get a very beautiful picture. If your heart is heartbeat very fast, I say forget it. If you cannot hold breath, forget it. All right. But this one is a very good tool nowadays to look at heart structure and to see any blood vessel blockage. I'll show you a picture. All right, these are all still picture, but in the rooms we can actually play around with it. Heart turn like that, and then we can change to color to what color you want. Green, blue heart, yellow heart. You can change the color, so it's quite fun. So basically, you can see the blood vessel is blocked here. You can see that this is a blood vessel that you have on the surface of the heart. The black color is the cholesterol. So over here, you can straight away see that, hey, uncle, you have a block here, and this is very tight. And what we can do for you. All right, so we can tell you that. And when we do the so-called angiogram, which is a gold standard, and we compare that, it's identical. All right, you see that? This is a narrow area, normal, narrow area, normal. So it's actually a very good tool nowadays. It's one of the good advancements in terms of medical cardiology. All right, so this is another picture that you have. You see the blood vessel come out from the heart. It's narrow and big. This black area are the cholesterol. And this is an angiogram. You can see it narrow, black, and cholesterol. And we can discuss what kind of treatment option that you have. So other picture just to show you, this how is it. This is a narrow cholesterol plaque. This is a narrow cholesterol plaque. You see big, small, big. All right. So we can know that, uncle, you need one stent to fix these blood vessels. You can see that these are the cholesterol plaque here and then here. So this is very tight. You can see this is very, very tight lesion, very, very tight lesion. So before we go in and treat you, you already know that, okay, I have here block, I need one stent, two stent. So you already know, all right? So this is one of the good medical advance that we have to know that how to treat the patient. And this is another example. You can see very tight lesion here, very tight lesion here. So this is CT angio, this is coronary angio. So it's identical. All right. If let's say we do found that you have a blockage, then we want to treat you, all right? Or we want to find out the angio is not the CT angio is not very conclusive or suspicious, then we can always do something called angiogram. And angiogram is a gold standard, as in today, gold standard. Nothing go beyond this test after that, all right? So this is a final test to say whether you got block or not, and what are the block and how to do it, all right? So basically nowadays, this is actually I would say, needle hole procedure. It's just a needle, all right? Needle hole. When finish, it just take 2 minutes, all right? And when it's done, it's just a needle hole, all right? Some people say very invasive and things like that. I said I commonly do this. Nowadays, it's a very, very common thing, all right? Basically, you enter the room, and basically what we do is that we put in a small plastic tube into the entry part of the heart vessels, and we inject a small amount of dye to see whether there's any blockage or not. As simple as that. all right? And usually you are alert. I always chit-chat with patient. Now I'm going to inject on you. You're all right. I'm into the heart already. It's done. It's finished. That's it. All right. So usually it's just or we can do it on the wrist, on the groin, and sometimes on the left side as well. All right. Any way that you can feel a pulse, we can go in, and it's a needle hole. All right. And the tube that we put in is 1.8 mm. It's very small. 1.8 mm. All right. So this is a test that we call angiogram. And basically, we want to look at 3 blood vessels, the right one, and the left have 2, one to the front and one to the back. So everybody have 3 blood vessels, left 2, right 1. And these are the ones that actually contribute to the heart. And some people have 5, 4. That's because extra branch, all right? But in general, everybody have 3. But sometimes, if God is very naughty, they want to put 3, 4, 5, 6, it's up to them. All right? Sometimes they put it wrongly also, God. We have, put it wrongly. So the thing is that everybody in general have like this. And depend on where you block, the symptom present differently. Example, if you have a high block, you can present with neck pain, jaw pain. If you have at the back, you have block here, you can present with back pain. If you have the right side block, you can present with epigastric pain. Commonly, the left front block here is a classic pain in the front, all right? So it depends which area it blocks. That's why the symptom in every individual who has heart attack present differently. You understand? Not all same, right? Where is the area that block? So how to prevent catastrophe? If you found problem, treat it. As simple as that. A drain is blocked, treat it. A blood vessel is blocked, treat it. All right? So we have 3 ways of treating: pill, spring, or knife. Which one you want? All right, but the doctor will advise accordingly. All right. So basically, any patient who have heart problem, we would like to treat them with a pill first. All right. The pill is that we have blood thinner. Commonly, is aspirin, Plavix, to make the blood go through easily and prevent clot in the blood. All right. And then we have the nitrate, which is make the blood vessels more relaxed to prevent it from getting tight and spasm. And we want to treat the rest of the thing like cholesterol, your sugar, and so on. And if, let's say, the lesion is very tight and doable, we usually offer spring, which is angioplasty. Basically, get it done with a spring, put it in and open up. And this one, I'll show you the picture later. And worst come to worst, all right? Say, too bad, uncle. It's too bad. We can't do anything more than that. Cannot be spring, cannot be medication. We ask for, bypass. All right? Those are very difficult case. So sometimes we do offer bypass. All right? So how do we decide bypass or spring, all right? So usually it's a 1 blood vessel block or 2 blood vessel block. We tend to go towards ballooning, all right? The more easier is it, we tend to go for ballooning. But if, let's say the block is very bad, 3 block, left main block, multiple block, and then involve many stents. I say 7, 8 stents, and then 100% block everywhere. Very hard vessel, difficult, So I said, you want to consider bypass, So usually we will discuss first. Yeah. Now, those days when the balloon technology is not very advanced, we tend to favor bypass a lot. All right. But as the technology in today, intervention technology is today getting more and more advanced, and more lesion can be treated, more difficult things can be treated. Bypass cases has slowly coming down a lot because taken all by us. Everything, no need bypass can be done. But all cases is individualized. All right, cannot be generalized, individualized, depend on the patient condition, depend on the blood vessel condition, depend on the patient comorbid condition. Then, and the family, whether they agree or not. Then we decide what is the best option for the person. All right. So all case, whether which way is going, is general individual. It's very individual. But in general, the more simple is it, tend to be on the balloon side. But more complex is it tend to be on the bypass side. All right, this is so-called a stand, all right, before it was opened up. And basically, this thing was actually put into the blood vessels, and we use a very high pressure to open it up like this. So this is how we open up a stand. And the balloon, we will take it out, all right? The stand will live in the body, and it will not rust. It will not rust, all right? This material is usually nowadays is cobalt chromium, and it will not rust, it will not move. And if you go to the airport with metal detector, it will not sound. All right? A lot of people say, okay, sound or not? It will not sound. All right? Okay? So it's very important. All right? So this is example, a cartoon that's showing that how a narrow vessel look like. We put in a balloon, we open up. So this is how we open up. And then we put in a stand, we employ a stand, and then the balloon go away. And we only left the stand. And this is how the blood vessel look like after we put the stand. All right? It's a plumber job. Sometimes I call myself plumber. All right? So this is an example of a young man who come and see me, who have actually a classic pain, who is smoking, in the office suddenly, not well, chest pain, sweating, whole shirt wet, a bit giddy, breathless. So the colleague saw, something not right, quickly go to the hospital. By the time we reach the hospital, first thing we saw the symptoms, we recognize symptoms. Number two, we do the ECG first. The moment the ECG show is immediate heart attack, all right, we go in and save it now, all right? The current treatment nowadays is go in and unblock it. Go in and unblock it. This is the current trend of treatment. So we go in, we found that it's blocked here, all right? Blocked here, 100%, all right? So what we do now is that, now is like I'm a plumber, all right? So we suck out the clot, this one. See this? All right? A lot of time after I fix, I show the patient, this is a clot that you have that's causing your heart attack. They cannot believe. Such a tiny clot can kill me. This one, that's all. All right? So once we suck out the clot, you can see the blood vessel come back, and whatever remaining is a cholesterol. All right? Cholesterol. So those remaining cholesterol, what we do is that we fix it with a stent, and you can see the blood vessels look normal. All right? This is what happened. This is what our job is. All right? The problem is that you must recognize the symptoms. You must come to the hospital immediately. Then we can do our job. But a lot of time, we do not want to wait for this to happen, because the moment you have a heart attack, the muscles start to damage. Then you are at risk of getting a weakened heart. All right? So a lot of time, we want to pick it up this stage, when it's narrow already. When you start to have weird symptoms, and then you come for a stress test, and we pick it up, we get it fixed before a heart attack. All right? So this can be done, provided you come and see us. All right? So this is another example, 99%. So he get a stress test done, and then we pick it up, we say something not right. We go in and do an angiogram and found 99% block. All right? We get it fixed. All right? Nowadays, technology is so advanced that this blood vessels is about 2 to 3 millimeter. 3 millimeter. 3 millimeter, you see, so small. And we can put a camera into the vessel. Camera, So the camera will pick up whether the blood vessel is fully expanded or not. Sometimes some of the blood vessel, after we do, they say come back really narrow and things like that. Not good. Why? Because the stent is not open up to the size of the blood vessels. Every individual, the size is different. All right? All you are tailor-made by God. All right? Tailor-made. So some of the blood vessels are 3 millimeters, some are 3.5 millimeters, some are 3.75 millimeters, some are 4 millimeters. So no one knows, So when we go in, when we fix it, to make sure that the stent size is properly open up, sometimes we put in a camera to see, you can see this is a camera, you can see the whole blood vessel open up. Then we know that, this one will last very long. All right? So the human technology today will reach a stage that we can put a camera into your blood vessel. You see how advanced are we? But the public, still don't listen to all these new advanced, diet and things like that. So we already reached a stage that's so advanced that most of the things we can do, we can help to save life. All right? So if, let's say, very, very bad, I said many block, you need to put 7, 8, 9 stand and things like that. I said it's not worth it to do a balloon and things like that. Sometimes I recommend bypass. All right? So this is called a bypass. Bypass basically cut open the chest, chainsaw the chest, open up the heart, stop the heart, take the leg vein, or do a connection, or take the hand, or take So basically doing a flyover. All right? These are called highway. Highway, so you pay toll, so these are blocked. All right? So all of us are international cardiologists. We are doing smart tunnel. So these are doing a toll. All right? So these are the one that is a final option. Let's say for very bad heart, we do a bypass. So usually for bypass, it's a major operation. All right? You go through a heart-lung machine. Heart-lung machine basically stop your heart, and your blood go through the machine and to circulate whatever is it. And we basically open the heart, chainsaw it, really a chainsaw, and then we do all this graph and connect all the flyover, Usually they say 3 bypass, 4 bypass, 5 bypass, and things like that. Depends on individual. All right, but it's a major operation. Usually take about 4 or 5 hours to do one operation, and stay in a hospital ICU for 2-3 days ICU, and then come out in the ward for maybe about 5 days to a week, and then you go home. And to recover back to normal, maybe take about 2 months plus minus. All right. So this is what we do. Is that this uncle is 80 years old, one blood vessel blocked. We get it fixed, half an hour fixed, and then he say, afternoon I want to go home. He's so happy. This one have very bad block, so after the 5-hour operations, stay in ICU for 2 days. He said, you can't go home yet. You got another 1 more week, you stay in hospital. To able to recover and go for a cup of coffee will take another month. All right. So this is the difference between angioplasty and bypass. Angioplasty nowadays, I would say a needle hole surgery. A needle hole surgery. It's not even minimal. It's needle hole. If I do it, you look at the hand, it's just a dot. It's just a dot. It's no different from your branular. It's just a dot. All right. So now you treat it. All right. So early treatment, treat the comorbid, treat the diabetic. All right. Because all these people, they have diabetic. 30% of them, they have diabetic. So treat the diabetic, because diabetic make the blood more sticky, higher risk of cholesterol deposited. And after that, if you smoke, worse still. It will be 2 to 4 times of the risk of heart problem compared to normal people. If you are diabetic, please control your sugar, exercise, diet, take tablet. If needed, according to doctor prescription, take injection. If, let's say, don't say, I don't want injection. All right? So control the pressure. All right? Make sure the pressure is controlled, because if the pressure is very, very high, you forcefully push the cholesterol plaque, you may at risk of getting a heart attack. All right? So always control the pressure within a normal limit of 120 to 130. Lower is 70 to 80. All right? The more normal is it, the more healthy you are. All right? And of course, control your cholesterol. The main culprit is cholesterol. Despite whatever they say, what we treat every time that the person block is all cholesterol, nothing else, and clot. Cholesterol and clot. It's all cholesterol. All right? So all this cholesterol come from where? Our best food everywhere around. All right? Every new shopping complex open, sure got good food. All right? So all eat. All right? So this is what happened. All right? All cholesterol. All right? And stay healthy. All right? Stay healthy. Stay healthy in the sense that no smoking. All right? Smoking is the worst thing in life. All right? I would say that. Worst thing. You pay money to buy illness. I'm telling you, you pay illness to buy illness. Because the smoke you go in, you damage the vessel wall, and cholesterol tend to stick. And when you get into heart attack, when you come and see me, I said, Uncle, you need 30,000 to fix the heart. I said, if you save the money those days and keep your wife to buy gold today, you probably have more. True. It's true. All right? So don't ever get into this. Okay? Basically, you are paying money to buy illness. Really. So you pay, so that you got more illness to come. All right? Stay healthy. Stay healthy in terms of diet. You can see this is don't exercise. This is exercise. And eat healthily, basically vegetable, fruits, fish, lean meat, chicken without skin, lean chicken, all right? Seafood with shell, try to avoid. Good one, crab, prawn, lobster, all right? Try to avoid. And good for antioxidant for the heart. Bean, all the beans, all right? Not soya bean, the bean, all right? All the walnuts, cashew nuts, and so on, all right? All berries are good. 30% of them bring down our oxygen. Berry, blueberry, mulberry, strawberry, whatever berry that you can think of. All right? Now, at the moment, no Australian berry, yeah? Because of the needle. All right? All right? So, all berries, all right? Oil, good oil are canola oil, sunflower oil, olive oil. Those are good oil. Those you should take. All right? Any palm oil, try to cut down. All right? Then you stay healthy. All right? Basically, today I'm teaching you how to prevent cardiac catastrophe. Today, we have the science and technology. You already know, I teach you. We can prevent all this disaster. All right? Detect the early detection by recognize the symptoms. All right? Make sure that this is a heart problem. You're not sure, see a doctor. Regularly check, and we have medical tests to see whether what is the problem. All right? And early treatment. If you have block, treat it. Don't in denial. Try this, try that, whatever, all sorts, vinegars, lemon, and so on. No, it doesn't work. And then treat the comorbid illness. If you're diabetic, cholesterol, sugar, treat it. And always, always stay healthy. All right? Move. move, then the heart will be good. All right? Okay, with that, I'll say thank you.
Thank you very much, Dr. Chong.
So this is my hospital, a garden hospital.
May I now invite up on stage Dr. Koh Kok Wei, who will be speaking on sudden cardiac arrest.
Hello, good morning, everyone. My name is Dr. Koh. I'm from Subang Jaya Medical Centre. So if Dr. Chong is a plumber, then I'm the electrician or the wireman. So I'm the electrophysiologist that specialize in heart rhythm abnormalities, right? Okay, now just look. I mean, many times that we came across this news, newspaper, online, that people, I mean, those young guy on field, they are healthy before this, they suddenly drop dead. You can see that fainted without warning and then collapse and then die. So almost every month you can see that this is 1 month apart. Another football player dropped dead on the field during a football game. Now what are the differences between this group of patients and those patients described by Dr. Zubin and Dr. Chong? And these are our own national athletes who a couple years ago died during a training session, collapsed. And you can see that what are the similarities between all these cases. They are young. Unlike those mentioned by Dr. Zubin, that obesity kills. But staying young, lean, fit, they still die. And all these are athletes now. Athletes, even though they go for screening tests, they go for yearly checkup, how come they still die suddenly? And they have almost the similar characteristic. They're always so fit and healthy, never complain of any sickness before. So, ladies and gentlemen, I hope that the next 30 minutes, I would like to shed some lights and teach you all how to recognize sudden cardiac death. What is the prevention of sudden cardiac death? Okay. Now, sudden cardiac death or sudden cardiac arrest is a condition which the heart suddenly and unexpectedly stops. It's unlike the case that you are very ill, you have cancer, you admit to the hospital, you have infection, and you die in hospital. That is not sudden cardiac arrest. Sudden cardiac arrest are those I mentioned earlier. Those are very fit, lean sportsmen suddenly die without any obvious causes. Now, if this happens, the heart stops, the blood stops flowing to the brain. And this is what causes death. And every minute, if you can see, counts. But every minute passes, that your chance of survival decreased by 10%. And by the end of 10 minutes, most of the patients die without any help. All right? Every year, I mean, almost 500,000 Americans die from cardiac arrest. And globally, all these deaths, more than the combined death of cardiac, I mean, colorectal cancer, all the cancer, HIV, firearms, so on and so forth. And unfortunately, most of these cases happen outside hospital. Now, what happens if it happens outside hospital? Most of the public, the lay person, will probably don't know what to do. They suddenly just collapse and, oh, this guy collapsed already. What to do next? So, and because of that, most of the time, more than 90% of the time, they died before reaching the hospital. Okay? And you know that in Malaysia, the top killer is still heart diseases. And when you have heart diseases, the risk of sudden cardiac arrest are very high. All right? Now, what are the difference between a heart attack and a sudden cardiac arrest? I think a lot of you all have been asking this in your mind. So, to simplify it, heart attack is a blockage in a vessel that supplies the blood to the heart muscle. And when the pipe is blocked, as described by Dr. Chong, the heart muscle died. And sudden cardiac arrest is when there's an electrical malfunction. Suddenly, blackout. And the next thing is the patient collapse. Okay? And the risk factor for the heart attack is already described earlier: high cholesterol, high blood pressure, sugars uncontrolled, smoking, and you have a family history of heart attack, you are at high risk of getting a heart attack. And those who are at risk of sudden cardiac arrest are those who have previous heart attack. All right, if you have a previous heart attack, you will have an abnormal tissue of in the heart, which is scarred from the permanent damage caused by the blockage. Now, this abnormal heart tissue will then generate abnormal electrical activities and suddenly make your heart beating either too fast, too slow, and makes your heart become an ineffective pump. So you can't pump the blood to the brain and drop dead. Those who have heart failure, there are many causes of heart failure. Of course, the number one cause of heart failure is heart attack. Then your heart will become very weak. And then you have a very high risk of sudden cardiac arrest. Abnormal heart rhythm, meaning that your heart either beating too fast, too slow, you're at risk of a sudden cardiac arrest. And of course, family history of sudden cardiac arrest. Now, let me just go into more detail one by one. The risk factor of sudden cardiac arrest, as I mentioned, previous heart attack. Family history of cardiac arrest. If you have a family history of sudden cardiac arrest, first degree family, meaning that your brother, your sister, your mother. Okay? Second degree means your grandfather, grandmother, so on and so forth. So if you have a family history, first degree, sudden cardiac arrest, suddenly die at the age of 30 plus without any illness, then you must watch out. All right? Patient with a ventricular tachycardia. Ventricular tachycardia means the heart rhythm abnormalities, as I mentioned earlier, beating too fast. Now, how do you know that one have ventricular tachycardia? If you always have feeling palpitation, if you have fainting episode, blackout or giddiness, and you are known case of a heart problem, then you have to ask your cardiologist, am I having ventricular tachycardia? And patient with a heart failure, meaning that the heart is weak, has increased risk of sudden cardiac arrest. Now, so how do we identify the risk? Now, we know that patient with previous heart attack has high risk of sudden cardiac arrest. Therefore, we must prevent it. Prevent a heart attack from happening. I think it's already been elaborated in length. Good control of blood sugar, good control of pressure, cholesterol level, all these things must go for yearly checkup and make sure everything is in good control to prevent your first heart attack. Okay? And those who are okay, no problem, you still need to go and screen. Even though you are young, as I mentioned, a lot of young people died suddenly without any reason. So you need to go for screening. Okay? And for those who already diagnosed with a heart attack, unfortunately, those who already diagnosed with diabetes, all these things, please listen to the doctor's advice. Have a strict diet, strict exercise, healthy lifestyle, and be compliant and adherence to the medication. A lot of patients come to me that they don't like to take medication. They hear a lot about herbal medication, traditional medication, and this thing doesn't work if you really have a real disease, all right? So, if you have a family history of sudden cardiac arrest, anybody recognize this guy? I think very famous. So he was the cause of death earlier part is heart attack. All right. Then later on, somebody mentioned that they have did a gene study, and also the autopsy showed that there's a thickening of the heart. Now, he was suspected to have a hypertrophic cardiomyopathy. I'll tell you later what is that. And those who died on the field, I think a few years back, autopsy showed that this guy, young guy, also have hypertrophic cardiomyopathy, a form of heart disease. These are athletes. Remember that? These are athletes. They go for screening. They go for stress test. They go for blood check. But sometimes you don't check the correct things. You ask the plumber to go and check the switch. It's wrong lah. So you have to ask the electrician or the wireman to check the switch. So this guy have hereditary heart disease. And you know that a lot of young patients, even though they are athletes, the most common cause of death, number one, is this hypertrophic cardiomyopathy and abnormal coronaries. Okay, what is hypertrophic cardiomyopathy? I mentioned so many times. These are heart diseases that only can be detected through thorough cardiac examination, such as ECG, the one that stick the lead on the chest. And also they put an ultrasound on the heart to look at the heart. Now look at this normal heart. The wall is normal size. It is not thick. Hypertrophic means that it's become thickened. Cardiomyopathy means heart disease. So if you have a heart that is so abnormally thickened, then you have chance that you will develop electrical malfunction in the heart and lead to sudden cardiac arrest. And echocardiogram, it's an ultrasound of the heart, can show that whether you have thickening of the heart or not. All right? And sometimes it doesn't even detect it through the normal ECG. And sometimes with the advancement of our technology, CT scan can find abnormalities of the coronary blood vessel. If you're young, you still complain of chest pain, we will still investigate and make sure you don't have all this problem. Sometimes we will perform CT scan in young patients with certain indication, just not to miss all these things. You see that this blood vessel, the blood vessel to the heart, the coronaries, runs between, it is a very abnormal blood vessel, runs in between two big blood vessels. You see, it's squeezed in between. So when you exercise, these two blood vessels will expand and compress the artery, and you die suddenly. It's like mimic a heart attack, all right? Now we even have MRI. MRI is a very advanced technology that can even characterize your tissue. Tells you whether, even though the echo is normal, MRI can tell you that there's something abnormal in the tissue. You are at risk of sudden cardiac arrest. Okay? Next, patient with the rhythm, heart rhythm abnormalities have increased risk of sudden cardiac arrest. Now, the simplest way to know whether you have heart rhythm abnormality, especially if you're a heart patient, is to feel your own pulse. Now, everyone can try to feel your own pulse. It is at the wrist, at the side of the wrist, you can feel. Do you feel the pulse? It should be regular. It shouldn't be too fast. It shouldn't be more than 100 beats per minute. It shouldn't be slow, less than 50 beats per minute. Either this extreme is bad. And also, it shouldn't be irregular. It shouldn't be like, no, that's very irregular. It should be regular, okay? And nowadays, there's a lot of application or smartphone that can detect irregular heartbeat. So if you have you feel palpitation, short of breath, you have fainting episode, so you can get all this app downloaded in your phone and purchase all this simple tool. It's like an ECG. I think they have the demo outside this hall. How do you do this? It's just by placing two fingers on the lid, and you can know your heart rhythm, whether it's normal or abnormal. Sometimes you need a special tool to detect, because all this palpitation doesn't come regularly. They only come at certain point of time, like today, Sunday, you have palpitation. By the time you go to the hospital, there's no more palpitation. It's like you are trying to catch a meteor rain. It's just waiting, but it never comes. But when you are not ready, the meteor shower came. So how do you detect all these things? You need to have a specialized tool to investigate. Like this is me holding a very small device in my hand. This is a tool that can be implanted under the skin, very small cut only, under the skin, just within 1 minute. And the device can stay in the body for up to 3 years without extracting it. And this can pick up a lot of information, especially you have intermittent symptoms that you couldn't detect. Or you go to like 10 doctors, all doctors say it's like ECG normal, everything. It's not really normal because they don't pick it at the correct timing. And sometimes you see all these irregular heartbeats only happens for maybe 10 minutes in a month. And these are all very dangerous rhythm. And if you have all this, you're at risk of sudden cardiac arrest. Okay, next thing is patient with a weak heart. Now I'm going to talk about a bit more detail about ejection fraction. So when doctors talk about this thing, this terminology, it just means that, your heart is a pump. If you're able to pump all the blood out, squeeze everything, means that you have 100%, yeah, but there's nothing, the heart wouldn't pump 100%. You just pump more than 55% the blood out is enough. So 55% and above is normal. If just able to pump less than 30%, means it's very abnormal. And it has shown that less than 30%, if your EF is less than 30%, you have increased risk of sudden cardiac arrest. Now this is like a insider news lah. The doctors don't like you to ask this question. So if you go to the doctor, if you have a heart problem, you just need to ask two questions. Number one, what is my ejection fraction? Okay, I'm going to teach you. What is my ejection fraction if you have a heart problem? If the doctor says it's 30%, then the second thing is, is increased risk of sudden cardiac death. You need to prevent it. You have to ask your doctor, do I need an implantable cardioverter defibrillator? All right, these two questions, remember this in mind. Now, Dr. Chong mentioned about pills, spring, knife. Now I'm going to introduce battery. All right. Now, this is the interesting story. So this guy is a physician from Poland. Then worked as a cardiologist in one of the hospitals in Israel under Professor Heller, the chief of medicine at that point of time. So he was treating heart problem. Ironically, the mentor have renal abnormalities, and 2 weeks later, died suddenly while having dinner with the family members. So Michel Mirowski was so sad and disappointed that he can't do anything. So he devoted all his life to what do you call that? To invent something small enough. That time they have a defibrillator. Defibrillator, we watched in the movie, right? Anybody that collapsed, they use the electrical activity to restart back the heart. So at that point of time, the defibrillator probably as big as this podium. And you can't obviously bring it all over. So they're trying to invent it and miniaturize this device less than the size of the palm. And it can be implanted under the skin, with of course some wires to the heart to detect 24/7 if there's any electrical abnormalities in your heart. And this procedure is probably more than keyhole, but it can be done under just sedation, and it's less than 1 hour procedure. All right? So we know that why this device has to be in the body 24/7, because when it attacks outside the hospital. You don't know. Right? And there's sometimes no symptom. So the only good thing about this problem is you die also you don't know. So die peacefully. That's the thing. Now let's look at this video. I think this video shook the world many years ago. Like this guy is a Hungarian footballer who was just, after a few minutes, came into the field. I can see that he is happy, fit. All of a sudden, you can notice something is wrong. This is the time where the heart's starting beating very fast. And the way he falls, you can see that as a cardiologist, we know that he has control loss of tone in the body. Now, when you see this kind of thing, this is actually ventricular tachycardia or ventricular fibrillation is happening at that point of time. And even though you do a CPR, if there's an electrical abnormalities, it will not revert by itself unless you are so lucky. Another footballer who had diagnosed to have hypertrophic cardiomyopathy was implanted an ICD and go back to the field. That player has an ICD. So he collapsed like the earlier footballer, but the ICD detected and within seconds, he gave the heart a shock. Immediately, he came back as though he just fell down. Nothing, and he survived that match. All right. And nowadays, there's a lot of type of defibrillator implanted all over the world to the athletes. You can see that this is under the skin. It's called a subcutaneous ICD. Okay, what to do if you do not have ICD? So I believe that many of you have read this news that came out a few weeks ago, that a footballer in Georgetown, I mean not a footballer, I mean he's playing football, suddenly he collapsed, and what did the teenager did was just performing a CPR and AED, automated external defibrillator, a shocking device to restart the heart. Now it's automated, meaning that the machine will give you instruction what to do next, and the machine can detect what type of abnormalities and give the shock appropriately. Later, I think they will demonstrate the CPR and also the AED machine. Now, survival with CPR, but no AED use before emergency service arrive is about 9%. So, meaning that even though you can perform a CPR, anybody done a CPR before on a real life basis? No. I don't think anyone here can last more than 3 minutes pumping the heart. It's so tiring unless you have 2 or 3 person that alternately do this CPR exercise. It's very tiring, and you need to consistently press the heart, the chest, so that it can pump enough oxygen to the brain. Now, as I mentioned, the electrical abnormalities, the malfunction cannot be restarted by just CPR. You need a shock, okay? If you don't have an ICD, the best you can do is to have an automated external defibrillator. All right, CPR does save life, and as well as automated external defibrillator. This is another case where it just happened, I think, a year ago, where this Dutch footballer collapsed on the field. And you can Google this name, and you can watch it on YouTube. What happened was, there was delay in performing a CPR and also delivering an AED to restart back his heart. I mean, it's okay. Right? And after collapsing, they had suffered from brain damage because of just by delaying the CPR by a few minutes. And they have also acknowledged the fact that they have delayed in instituting the correct treatment. Now, just a few days ago, I think one of the doctors have write a letter to STAR, say that we have problems in Malaysia because we have lack of this machine called AED in public places. Now, if you, I mean, does this office have an AED? Sorry, they will never invite me later, next year already. They need to have, I mean, developed country, all the public places, they have AED, all right? But that's still not enough. If you have the AED machine, you need to train how to do a CPR and also doing it. So one of the gym center, they have AED, but they are not having anyone who are able to use the defibrillator. So I think more and more hospital, more and more non-government organizations are opening up a CPR and AED courses for the public so that they can learn and save their loved one if needed, all right? And the impact of public access defibrillator on survival, you can see that without any intervention, sure die, all right? And you have a average with CPR alone, your survival increase a bit, but if your AED can come within 3 to 5 minutes within reach, then your survival is more than 70%, all right? Now, you can go to our booth. Ramsay Sime has also have courses of CPR and basic life support for the public. The National Heart Association also, you can go online and just book for the courses. And so, ladies and gentlemen, I'm going to summarize my talk. So, in essence, the difference between heart attack and cardiac arrest, although most of the cardiac arrests are due to heart attack, all right? Cardiac arrest happens when there's electrical malfunction, very sudden one, drop dead. And warning signs of heart attack is all those described, chest pain, shortness of breath, those typical ones. And many times for cardiac arrest, there is no sign, but you can recognize the risk. What are the risks I mentioned earlier? If you have heart attack before, if you have a very weak heart, if you have a rhythm abnormalities, then you are at risk of sudden cardiac death. If you have a family member die at a very young age unexpectedly, you have to go to consult your cardiologist, all right? And how to tell the difference? Now, very simple. Anybody that collapses in front of you, you just have to ask yourself 3 questions. Whether the patient is responsive or not, ask him question, hello, hello, are you okay? Check for their pulse. How to check the pulse for patients that have collapsed? Here. Everyone can feel just beside the throat, on the right or the left, you can feel pulsating, right? This is a bigger artery than the hand. Can you feel that? So that's the pulse. And whether the patient is breathing or not. All right? Now you can look on the right and left of your neighbor. Hello, hello. Are they responsive? You can check their pulse and see whether they're breathing or not. If not, what are you going to do? CPR and get the automated external defibrillator. All right? Okay, with that, I would like to thank you for your kind attention. Yeah.
Thank you very much, Dr. Cohn. Ladies and gentlemen, please do stay on as we have a Q&A session with our doctors. May I please invite up Dr. Zubin, Dr. Chong, and Dr. Koh up on stage for the Q&A session. Ladies and gentlemen, before you proceed with the Q&A with your questions, please do state your name, let us know where you're from, and we encourage you to keep it to 1 question per person so that we can get to as many people as possible. Ladies and gentlemen, our doctors up on stage. If you have any questions, please raise your hands. Again, state your name, where you're from, and keep it to 1 question per person. Thank you, ladies and gentlemen. We have a gentleman up front.
Thank you. Good morning to all of you. I'm posing these questions to Dr. Chu.
Yes.
Good morning to you, sir. You have mentioned that when a person after getting heart attack, the heart will be damaged. Most likely the heart will be damaged. What, after installation of a stent in one of the arteries, can we consider the heart has been damaged? That is number one. And one more question, please. During the CT scan, during the process of CT scan, usually you all will instill some dye or something like that. Okay. After the treatment, the procedure, can the dye cause any side effects later? That's all. Thank you. My name is Panjamurthy. I am from Sentul.
Hello. Yeah, thanks. Thank you for the questions. It's interesting. A lot of time the heart attack, the damage of the heart depend on two things. One is that how high is the level of the block. All right. If the block is at the lower end of it, so the damage is little. Number one. If the block is at the high end, which involve the more area of the heart, then it's a big damage. Number one. Number two is that how fast you come to see us to save you. All right. The moment you come in, you got pain now. ECG show heart attack. You go in, suck out the clot, the blood go down, the damage is minimum. If you overnight, the muscle screaming whole day, no oxygen, the next day you come and see me, all dead. So it depends, number one, where is the area of the block. Number two, how fast you come and see me. This is the only time for any rescue, they say time is muscle. So the earlier you see me, the earlier your muscle got oxygen after I suck it out, the fastest it recovers. The moment that you come late, all the muscles already dead, it doesn't make any difference already. Okay. The question number two is that, for people who have normal kidney function, all right, the dye that we inject to you after the scan, all right, the moment you go home, drink water, it pass out in the urine, zero. Clear, nothing. Right? Oh, the stand is the same thing, exactly like what I said just now. Right? It depends how much muscle damage. It depends on where is the block. All right. And number two is that when do you come and see me? All right.
Good morning, doctors and fellow listeners here. I'm Albert, subscriber of the Star newspaper, and my question is, even 2 years back, you see, I was a bit hungry. I was about to go to the stall to have my teh tarik, but before I reaching there, you see, suddenly I collapsed, and a passers-by came to my aid. I was revived, not revived. I came to normalcy, you see, and it happened to me long time ago, and my son-in-law took me to GH, and they fixed, you see, certain gadgets, miniature gadgets, and asked me to wear it for a few days. And when I returned there, they said there's nothing wrong, you see. Do you think, but I have a stents now, not before. Do you think there is a heart failure or heart problem with me? Thank you.
Thank you for the question. I would like to answer the question. As mentioned, most of the time the cause of collapse is due to rhythm abnormalities, and the main cause of it actually is heart attack. All right. So this is the typical story I just elaborated earlier. No symptoms, suddenly you just collapse. So you're the lucky one that able to wake up from the event, because sometimes the heart itself will revert back into normal electrical activities. So the next thing you should do is to do a thorough check on the heart. Now, most of the time, the test that is normal doesn't mean that you are totally normal, because sometimes you don't check at a particular correct area. All right. If your car have a engine problem, then you check the tire, it will be normal. Correct or not? So the next thing you should look for is the cardiologist, so that they can do CT scan, they can do angiogram, and then next they can do specialized electrical testing on the heart. And I mentioned also very typically that this symptom doesn't come often. They just come one time, then just silent for a few years, and then attack another time. So it's very difficult to catch this moment. It's like a Kodak moment, You need to catch the moment. So sometimes you need to have a specialized device that can be implanted under the skin to monitor your heartbeat 24/7. All right.
Morning, my name is Yo. I think it's only fair to give Dr. Zubin a question now. Okay, it's regarding weight, BMI. First, two questions. One is, there's this talk about BMI between Asian and European. You need to differentiate. It doesn't work for Asian, the scale for European. And two is BMI and then your muscle versus body fat. Say a person like me who's 180 cm, it should be, say, 80 kilo. But if I'm running about 84 to 85, but there is the argument that you do a lot of gym workouts, your muscles are really firmed up. So there is that tolerance that is allowed. Is that true or not true? And if it's true, how much is the tolerance?
Okay, so the first question was us Asians and the masaleh. Yes, I think about 10 years ago, there was a revision or there was a suggestion from the WHO, specifically from our Asian colleagues in Singapore and Hong Kong. They decided that we should be thinking of lowering our threshold up to 28, from 30 to 28. But those are just numbers, as you say. So just for us to communicate between each other, yes, we say, let's use 30 for obesity, or if we are here in this country, then we can certainly bring it down, because we seem to have an extra kind of burden with disease, even at a lower BMI, 28. It is because of our slightness in our size. But no, there's three of us here. I'm slightly larger than my colleagues here. Do I use the masaleh BMI? I would like to think so, but maybe for me to be a bit more careful, I will still go back to the 30. Go back to 28, for example. Okay, for somebody with who's an athlete who does weights, yes, your muscle will just mean that your BMI will not be the same as somebody who lives a sedentary lifestyle. That is similar to somebody who's a bit more on the elderly side, and those who have are of short stature. So it's not just BMI that we use other things such as waist circumference and the ratio between the waist and also the hip circumference. Those are all just mainly, one, research tools for us to use when we do our experiments. Second is how we communicate between patient and doctors to doctors. So we look at one patient, we have one BMI, and it can't be just the number that we're treating. Yes, there are some differences between a patient who has got more mass. But saying that, even if the patient is very, very healthy, a high BMI does not mean that if they are lean, they are absolutely okay with a high BMI. It's really something which we still don't have a clear grasp on if it's just looking at BMI. It's not perfect. Okay, it's not perfect. Does that hopefully answer your question? Okay, all right.
Thank you very much, Doctor.
At the back.
Thank you, doctors, for your very informative talk. My name is Osman Kasim from Kuala Lumpur. Question is, treatment of somebody with water retention or liquid retention, and who also has a heart problem. There's always a delicate balance between the pills that you take. So can I have a bit of elaboration on this aspect of it? Thank you.
Okay, I got the question. So if you do have water retention, it can be as simple as having veins which are not pumping well. So you may not have any heart disease, you may not have any problems with your kidneys, and your liver's all right, but you still have water retention. Do we need to treat that water retention? So we still have to look for the other simpler causes of water retention. Maybe it's just unlucky we are at a elderly stage of life and we just have problems with water retention, that will not need any extra medication because it may cause more problems. The other thing is some of our anti-hypertension medication may cause some leg swelling. So look for the medications which can cause edema, for example. That's the term which we use. But then once we get to the stage where the patient has got heart failure, they may also have renal failure, so kidney disease. And yes, you're right, we have to make sure that by prescribing the right kind of medications, making sure that we have a way where we can tell the patients, yes, you need to drink enough water for you to hydrate yourselves, look at the weather, look at what you do on a daily activity kind of basis. If the patient is still active, still working outside in the field and needs to drink water, then he still has to, because if he does not, then maybe the kidneys will be in trouble. So all of this means that the patient may be in kind of constant contact with the doctor on a more regular basis. Over time, the patient will be able to adjust his medications. We have patients who will adjust their Lasix or their furosemide, for example. On certain days, they may be taking one tablet. On some days, they won't be taking one tablet because it's just a water pill. And there are some situations where we have heart failure nurses. IJN has already started, for example. We are not there yet, for example, but certainly in some patients where heart failure is the main problem and something specific like water retention, it does take some time to understand what that patient needs to do. But just by giving a blanket rule, you have to drink only 1 liter per day or more or less, may work for some patients, but not for all. It's on a personal basis that we need to adjust this. Yeah.
Can I just add on? If you have a heart-related problem, for example, heart failure, remember the 2 questions you should ask your doctor. I know a lot of doctors don't like to listen to this because they always think that this patient trying to act smart. But these 2 things are very important. Number 1, again, what is that? What is my ejection fraction, all right? So if the ejection fraction is low, less than 30%, then the second question is, do I need an ICD? A lot of times when you are taking medication and you feel well, all right? You feel better because medication is really very important. I'm not saying that everybody needs the implantable cardioverter defibrillator. Medication is very important, but there's a certain limit, all right? And then medication, if it doesn't work beyond that, I think the risk of sudden cardiac arrest are still there, regardless of any medication you take. If your EF is still below 30%, you are still at very, very high risk of cardiac arrest. So a lot of my patients was like telling me that, oh, I'm taking medication, I feel very well. Suddenly they just dropped it one day, and the family member asked why. So this is because they don't have protection against sudden cardiac arrest. All right.
Thank you very much, Doctor. We have a question from a gentleman right at the back.
Hello. Hi, good morning to 3 honorable doctors. My name is Lam from Puchong. Okay, my question is regarding about palpitations, being the symptoms of potential sudden cardiac arrest. First of all, I'm involved in certain sports. Okay, and sometimes, obviously everybody knows that after you do a certain sports, you may have a high rate of palpitations. But to me, previously I had a bout of something like difficult to breathe. And I went to do the checkup and they say, as usual, everything's clear. But that incident causes me to have a phobia to participate in my respective sports. Because every time I participate in my sports, I will have this palpitation feeling. So my question is, what's the relationship between this palpitation with the sudden cardiac arrest, even for possible normal people? I'm not saying I'm very normal, but possible normal people, because the heart it's controlled by electrical signal, which sounds like very sensitive. It's like can break off anytime, even to normal people. So what are the risks if I have a very high palpitation rate, and sometimes when I go for a competition, you just want to have you keep on want to winning, you keep on want to continue the game and things like that, and you ignore the palpitation sign. Will that increase my rate for SCA? Thank you.
So yeah, so it's very common to hear when people participate in competitive sport, they die suddenly. That is because they have risk of sudden cardiac arrest. Palpitation, by and large, is most of the time is a benign disease. There are a lot of types of condition associated with palpitation. But because of the gravity of some of the disease that can suddenly cause sudden death, we investigate very thoroughly in most of the patients, even though it's young. So a lot of people don't understand why young patients still go for stress test, ECG, medical checkout, these things. It's because of this problem. So all these are non-invasive tests. It's a screening, so it's like nothing into the body, just run on the treadmill, people will be monitoring, so it's very, very safe. So there's no reason why you shouldn't go for a screening. And after the screening, if everything is still normal, there are certain tests to detect, as what you say, sometimes it comes, sometimes it goes, so the kind of thing to monitor intermittently. Okay? And sometimes we still couldn't find it, then we have to go for more invasive one. Invasive means that something have to be put in the body to check it. So what, as an electrophysiologist, this is my bread and butter, what we usually do is to admit the patient to do a test called electrophysiology study. And many of us are not aware what is the disease because it's so rarely done. So it's actually a very common procedure, and it's actually very, very safe, and even safer than coronary angiogram. So we put a wire into the body, we stimulate the heart, and see what is the abnormal rhythm that is generated, okay? And we treat accordingly to that. And not all cases are bad. If your heart structure is normal, echo shows that it's normal heart size, no thickening of muscle, stress test is normal. Most of the time we just find a very benign cause called supraventricular tachycardia or very non-specific palpitation that you just need to be reassured. Right. Anything you all want to add on?
Thank you very much, Doctor.
Good afternoon, doctors. My name is Razak, and I'm a heart patient. I had a heart attack on the 3rd of April this year, and I was rushed to PPUM. I had an attack about 10 o'clock, and they had to do angio on me by the time I arrived at PPUM 2 hours later, and they had to do 3 stents on me. My question is, I've lived 59 years without having to visit a doctor. I was born in a hospital, and I never had to go to the hospital, and I had an active life. I ride super bikes, do all the heavy activities, extreme. And in April, I felt that there was some sharp pain on my chest, as though somebody poured hot water on my heart, and I collapsed, and I was rushed, and they gave me 3 stents, and after that, I was on drugs. Okay? So they gave me 4 types. One of it is the Brilinta, and then, as you mentioned, aspirin, and then the cholesterol, okay, and I think another one was something to do with to prevent you get gastric, okay? So my question is, how long do I need to take that? Okay, it's a good news for the drug company, of course, whole life, or is it, things like, and then he gave me first few months, he monitored. Okay, doctor, my LDL was almost perfect. I think about 4, okay? My blood pressure was 110/70, sometimes 105. I went to two separate doctors to be sure, okay? PPUM and University UITM Hospital, and Hospital Selayang, to get because I was not sure that doctors, because sometimes they, I don't know, I've heard that, drug companies are very happy with the doctors, and they're not cheap, Brilinta. My question is, do I need to take Brilinta? Because it's a company. Is there an equivalent? Because if you go to one particular hospital, they tend to give you Brilinta. I'm not against Brilinta if there's a company from Brilinta. But second type is, I'm an AB plus. Okay? Is there a relation between O, AB, A, tendency to get heart disease? Because I've read an article and there's a doctor who also told me, if you get this kind, high tendency you get heart attack or SCA, whatever you call it. Okay, is it true? And then the third one is, my question is, I've been on this drug. I was told not to take grapefruit. Statin, something to do. I saw it was stated, do not take grapefruit or its juice or its extract. Anything to do with citrus. Is it true?
Thank you very much, sir.
Okay, thank you, Doc.
Okay, thank you for the questions with that. You still alive? Make sure you ask Dr. Koh, what is an EF? All right. Okay. Basically, is that patient present with heart attack can be various symptoms. I told you, not necessarily pain. This one is sharp, and he said, hot water pouring on me. All right. So it's very unusual. But the thing is that it collapsed. All right. So every individual present differently. So if you're not sure, go to the hospital. Number one. Number two is that what he has is actually a cholesterol accumulated over time. All right. Without knowing, because if you have screened it, you probably have picked it up earlier, and then we can get it done before any catastrophic event happen. So this is one. The other thing is that if what happened is that the cholesterol plaque ruptured, it formed a small little clot, block off completely. The heart got shut off and it collapsed. So we went to the hospitals. Things was done. All right, and then after you discharge, we usually give you two main medication, all right? One is a blood thinner and one is a cholesterol pill, all right? The rest is all etc. So the blood thinner for any person who have heart attack is 2 blood thinner. Any brand will do. I don't favor any brand. Any brand will do for 1 year. After 1 year, you need 1 blood thinner, basically, I say, as a lubricant for yourself, all right? Basically, when you have a heart attack, you can also high risk of getting stroke as well, all right? Because the cholesterol can deposit everywhere. Heart, I can fix it. Brain, I can't fix it, all right? So basically, if you have a heart attack, you need a blood thinner for life, all right? Basically, to prevent you getting heart attack and also stroke. These are the 2 main organs is most important in our life, all right? You can survive from heart attack, but you may develop another stroke. So blood thinner is to prevent you from getting both of these, all right? Any brand will do. Brilinta is one of the most expensive one, not my favorite because I think the cost is too high. But individual doctors, it depends on their own preference. Some people like to wear black shirt, some people like to wear red shirt, it depends, all right? But whatever is it, after the heart attack, 2 blood thinner, and after 1 year, standard, this is around the world, after 1 year is 1 blood thinner, all right? Cholesterol pill is needed because initially that is because of the cholesterol. But once the cholesterol is coming down to normal, usually we have people who have heart attack, we want the bad cholesterol to be as low as possible to 2.4, all right? So if you can maintain that without medication, fine. But if you cannot maintain that with medication, then we put you back to medication, all right? But regularly, we advise you to check your blood every 6 months to a year to know what is your level like. Okay, because we do not want you to have another heart attack. We do not want you to have another stroke. Okay, and third question is the blood. Okay, there's no study on that. I'm not sure whether there's somebody do that. But on our observation is that blood type is not that important in this part of the world. I don't see any difference between the blood type. All right, nobody do this blood study on this part of the world. But today what we see is food, environment, smoking. We see younger and younger people, it's all food, all right? It's all cholesterol, it's all food related, not genetic related. Don't blame on the gene, blame on your mouth, what you eat. Oh, all right. The statin, for the grip, I don't see there's a problem. All right. So for statin, if you take statin, all the food you can take. But usually, if you take statin, some of the doctors will actually recommend you to take Q10, all right, as a supplement for the enzyme in the cell. All right, called Q10 enzyme. Usually, I advise for 100 milligram per day. All right, this is for enzyme. But fruits and food, everything you can take. All right. So for people who actually take heart medicine, there's no much interaction with whatever daily food that we take. The only one that we have problem is warfarin. All right, warfarin, there's a big issue. All right, so this one cannot take, this one cannot take. But nowadays we seldom give unless for selected patient. Thank you.
Yeah, let's just add one more thing. I mean, you were well, you were fine, you were healthy, you did some exercise, and you were active on your bike, right? So, you were asymptomatic for a long time, and suddenly you had the heart attack. And unfortunately, we, as doctors, when we put in a stent for the heart attack, we don't cure you. Okay, what we do is we just open up the blocked vessel, and whatever processes that we had for the past 40, 50 years, that will be ongoing, especially if we don't treat them well. For example, if you've had some high cholesterol for the last 10, 15 years, that will carry on. So you have three main vessels, and what we see occasionally is you have a heart attack in one vessel, and the patient within the next 3 to 6 months will also be at further risk of having another heart attack, maybe from the other lesion. So that's why we seem to see this a few times. We have seen it a few times, certainly, and we are treating the other stuff as well. We are treating the cholesterol, making sure that the stent stays open for as long as possible, and that's why it feels as a burden for us to tell you to just continue with the medication. But so far, from all the research where we follow up our patients after a heart attack, after a stent, even after a bypass, we are able to see that with statins and aspirin or Plavix or Brilinta is to just maintain that health for as long as possible. That's one reason why.
Okay, we have a question right at the back there first.
Yes. I'm 72 years old. Recently I went for a hiking expedition to Mount Kinabalu, and at the height of 1,500 meters, I experienced very heavy breathing difficulties. And I was wondering what happened, because every 50 or 60 meters I had to stop, to catch my breath, before I could continue, before I could proceed. So I was wondering what was my problem. And before this expedition, I went for a medical checkup, and the doctor had certified that I was okay. And I'm a regular, long distance runner. So I was just wondering whether, doctors could enlighten my problem.
All right. There are a few things. Number one, all right. Number one is that make sure it's a thorough check. Okay. Make sure it's a thorough check. If let's say all the thorough check is done and is fit, all right, is fit. Then the second thing is that, at that moment there are two things can happen. Number one is a stamina issue. All right, because climbing Kinabalu Mount is not something easy also, all right, it's a stamina issue. You must remember that running around the ground and climbing up is a different set of exercise, all right? So let's say if a stamina issue, then you have to train up your stamina. The second issue, is it a mountain sickness, high mountain sickness? Not everybody can accommodate themselves at a high mountain. Because we are here, oxygen is a lot. When we go to the high level, the oxygen level become less. Whether your heart is normal, even despite normal people, sometimes they reach a high altitude, they cannot take it. All right, it's called high mountain sickness. So they cannot breathe, giddy, sometimes can even fainted. All right, that's why they call it high mountain sickness. And in order to accommodate high mountain sickness, is individualized. Number one. Number two is that you must be able to. Some people they call it acclimatization. They have to reach certain level to make sure the body fit it, and go to another level, make sure they fit it, and then go in. Example is like Tibet. All right, go to Lhasa. If you fly in direct, sometimes they go down, they cannot breathe. Even you got a normal heart. That is why they build the railway, from China to Tibet. In the train is a pressurized oxygen to slowly accommodate your body to the height. So by the time you reach at Lhasa, your body is suited to that. So your chances of you getting mountain sickness less. But few days later, you may develop it. So it's individualized. Most important thing is that before you do any of these strenuous activity, get your heart thoroughly checked. All right? But let's say the heart is thoroughly checked, it's no issue, then you don't have to worry. But you also have to understand that stamina is individualized, mountain sickness is individualized. All right? So you cannot say, doctor say I'm fit, but why I'm breathless up there? Okay? Thank you.
Thank you very much, Doctor. We have time for one last question. The gentleman over there.
Thank you, Doctor. I have one question regarding blood tests for heart attack. A few years ago, we heard of troponin 2 being developed, and hopefully now, I don't know whether it's in the market, we can detect heart attack, minor heart attack going on all the time. So that's one question. Sorry if I can ask another question, which was stimulated by Dr. Chong just now. Briefly, just now he was talking about palm oil. Don't take palm oil. I thought palm oil was good. Thank you.
Okay. Troponin. All right. In the blood we have the many cardiac marker. So cardiac marker come from the cell of heart muscle which is damaged. So heart muscle, the cell, if the oxygen didn't go down, the cell screaming, pain, no oxygen. So when there's not enough oxygen, it will break. The cell will die, break. The moment it breaks, it releases cardiac enzyme or cardiac marker. So each cardiac marker is released, you go into the blood circulation and detected by our blood taking. And each of these cardiac marker is released at different time. All right, that's what we know. We have cardiac CKMB, we have LDH, we have troponin, and so on. Among, at the moment, the most commonly used, one of them, you have to use a few, is the fastest we detect is troponin. It's released between 2 to 4 hours time. Sometimes if you got a heart attack, you come very early. When you check the blood, all negative. Does not mean you have no heart attack because it's too early, that the enzyme is not released into the blood to be picked up by our lab. All right? So if you come few hours later, all positive already. All right? So of course, all the hospitals have those markers. It's standardized. All right? And it's been used widely around the world. There are some newer markers like myoglobin and so on, but it's shorter the time, but the thing is that it's not widely available and very expensive and not easy to interpret. So those, we have not been using it and not commercially available at the moment. At the moment is CKMB, CK, LDH, and troponin. Troponin is widely used because it's very sensitive. All right, so this is. The second one is that oil, we have many oil, all right? So the best oil, I said is actually canola oil, sunflower oil, any of this oil, olive oil are good oil. Palm oil, try to cut down because palm oil have a lot of unsaturated fat, all right? When you go into the body, usually the first go is fine, but a lot of time, if you cook at home, it's no issue, but in outside, whether it's a hawker store, 5-star restaurant, hotel, or whatever is it, a lot of time the oil is recycled and they buy cheap oil. Seriously, you can't taste the difference between good oil and bad oil. So when they recycle the oil and a few times and things like that, the radical become increased. And that's when you eat the food, become a bit more and more unhealthy. More and more unhealthy, So the best for oil, is, I would say, olive oil, canola oil, sunflower oil, and so on. Of course, you depend on what you cook and how much oil you put, all right? Because the palm oil is good for fry. All the rest of the oil you cannot fry, because you fry olive oil with the fish become black, because the particles are not stable, all right? You will break, so the fish will become black, all right? So whatever is it, the most available oil today is still palm oil. Well, all right, use it in small to moderate amount. Don't recycle it. All right, thank you.
If I may add on the troponin T, a reminder that if a troponin T is negative, means that there's no raise in the cardiac enzyme, it doesn't mean that you don't have a heart attack. Remember what Dr. Chong said, if you have a blockage in the artery, your cell die and there is release of the enzyme, the breakage of the cell. But what we know that heart attack is a very dynamic process. It's a spectrum. You can have suddenly a very narrow blood vessel, form a blood clot. Maybe it just occlude the blood vessel for a while, and then body naturally just release it. So there's no cell breakage. So that's why the troponin T may not be raised. So sometimes we still depend on symptoms, and sometimes ECG, the ECG that is stick on the chest. And if any of these abnormal, we still may treat as a heart attack. And sometimes that's why we, even though all this normal, based on high suspicions, because you have very high risk factor, you are diabetic, high cholesterol level, you still may warrant a hospitalization for observation. And we may need to repeat all these cardiac enzyme ECG at certain interval.
I think that's all the time that we have for questions today. Let's give our doctors a round of applause for taking our questions and for their talks.